I cannot see the participant.
You can't?
No, I can't. I'm not quite sure why. I don't know how many is there, and I'm not quite sure.
So far it's 24. If someone asked any questions, I will tell you.
And I prefer in a coffee discussion, but I want to see the names. Anyway, let me see if I can manage. I will stop the sharing for a minute and see.
Sure.
Yes, this is the participant, so I will put it here. Then this is the sharing. Okay, let's start. I can see now.
Okay.
What do you need to know in breast and endocrine surgery before you go to exam? And I will focus in OSCE more, but if there is something important in the written, I will say it. Let us start with the fibroadenoma. Fibroadenoma is a benign disease. It will present like small, it could be small or big, but anyway, a mobile mass, usually non-tender. Mobile, we call it the mouse of the breast. In the ultrasound, it will show like this, hypoechoic, isoechoic, oval in shape, isoechoic and smooth margin. And that's the way we diagnose the fibroadenoma in the images. To complete the triple assessment, we have to do biopsy to make sure this is a fibroadenoma. So if I ask you, Shari, how would you manage this patient?
We do a core biopsy to make sure it's fibroadenoma.
This is what I said. I do the core biopsy and this is fibroadenoma. How would you manage?
We watch and wait. We monitor the patient. Follow up.
So follow up how?
Ultrasound, like regular ultrasound.
Ultrasound and physical examination every 6 months.
Every 6 months?
Every 6 months. Okay, so we will follow up the patient, reassure her, do ultrasound and physical examination for every 6 months. And if stable for 2 years, we will do it annually. Stable for 2 years, then we will just follow it clinically. Clear? Clear?
Yes, doctor, it's clear.
This is the fibroadenoma if we decide to remove it surgically. What are the indications to remove the fibroadenoma? So what is the surgical indication for fibroadenoma excision?
Patient preference, if the patient wants to remove it?
No, I don't want to remove it for every single patient. If the patient has 1 centimeter mass and she wants to remove it, I will remove it, no?
Doctor, it should be a giant fibroadenoma and it should be rapidly growing.
So number 1, if this is a giant adenoma, what does giant adenoma mean?
4 to 5 centimeters.
4 centimeter, or in some textbook, they said 500 grams. So if this is from the beginning, big, huge fibroadenoma, 4 centimeter or above, we need to remove it. What is the second indication?
Rapidly growing.
What do you mean by growing?
Rapid. Like
yeah,
it's fast to grow.
What rapids mean?
It's increasing in at least 2 dimensions by 20%.
Yes, this is the increasing. Anything more than that means rapid. So any increase in 2 dimensions. Can you mute your microphone if you are not answering? So this is the fibroadenoma. we take this is one direction and this is another direction. Then in other imaging, we have also the third dimension. So we usually measure the fibroadenoma in 3 dimensions. Any increase by 20% in 2 dimensions may mean this is a rapid growing. Anything more معناته إنه rapid. So at least 20% in 2 dimensions. Okay, we will agree to remove it based on patient request if it is big or we think there is some pain which we can see it clinically, yes, but other than that we will not remove it. Even if she asks us, the patient, even if she has a history of breast cancer, usually we don't remove the mass if it is less than 4 centimeters. Okay, clear for fibroadenoma?
Doctor, do we do a mammogram?
معناته I need to go back from the beginning. Forget about the fibroadenoma. Who are with me? What's your name?
My name is Badr.
ما اسمعك. بدر?
Oh.
Badr, okay. Let us start from the beginning. If you have a patient with any kind of breast issue, how would you manage this patient? What is your approach to diagnose this patient and manage her or treat her?
It's basically, it depends on the age and
No. I didn't ask you about depending on the age. What is your approach to?
And then it's triple assessment.
Yes, excellent. So triple assessment. What is triple assessment?
It's a history, physical,
yes,
and then imaging, and then biopsy.
Excellent, ممتاز. So history and physical, then imaging, labs, and biopsy. What is the standard in form of imaging? What is the standard?
If the patient is less than 30, we do ultrasound. If the patient is more than 30, we do mammogram. Or if, let's say, if she was less than 30.
Generally, we say the standard is mammogram, but there are exceptions. One of them, as you said, if the patient is less than 30. What are the other exceptions? So the standard is mammogram, but exception number 1, age. If the patient is less than 30, we'll do ultrasound. What is the other exception?
Pregnancy.
Pregnancy. We cannot do mammogram, so we will do ultrasound. What is the third exception?
Mastitis and abscess.
Pain.
Inflammatory abscess or mastitis. So there are the 3 conditions in which we need to do ultrasound, not mammogram. So the standard is mammogram, but we cannot do it if the patient is less than 30. We cannot do it in pregnant women. We cannot do it in the case when the patient has abscess or mastitis. Clear?
Yes.
Okay. And what is the standard in form of biopsy?
Core biopsy.
Core biopsy.
Core biopsy. What we mean by core biopsy is true cut biopsy. What does that mean? We mean it is not a fine needle. It's something bigger. It's still with a needle, 16 gauge, but it's bigger than the FNA. FNA is 21 or 23 gauge. Clear?
Yes.
Clear for the doctor who asked. I forget his name. Is it Badr correctly? I hear it Badr, or I'm wrong?
Yes.
Okay,
So
clear,
we said
Badr?
core biopsy. We said
Yes, so
biopsy is core biopsy.
So in this case, and I didn't give you an age, but the image here is ultrasound. But you can find fibroadenoma in young or younger than 30 or more than 30. So if the case is younger than 30 أكيد you will do ultrasound. But if it is more than 30, you will do mammogram. In some cases, we cannot do mammogram or ultrasound, we will do MRI. But in this image is ultrasound, and this is an MRI. MRI is rarely we do it for diagnostic purpose, but we can do it for screening, and in screening we may find some fibroadenoma. So next case, this is more than 4 centimeters, so this is a giant fibroadenoma. Okay? Next. What can you see here?
Cyst.
Describe it. I didn't ask you about diagnosis. Describe it. What is this? In the exam, I don't want you to tell me cells. What is this first?
Ultrasound.
Ultrasound. Excellent. Then what are the findings in the ultrasound? Hypoechoic mass. This is the one, yes. And with what? Smooth. Yes, there is a acoustic shadow and there are smooth borders. So this is
benign cyst.
No, benign.
Not complicated.
Simple cyst.
Simple, yeah, simple.
Simple cyst, okay? I don't want you to be confused. In the OSCE exam, and I don't bring ultrasound. I bring usually mammogram because standard is mammogram. So you need to know how to read the mammogram. But I'm trying to show you. Can you use the microphone? Thank you. But I bring the imaging here for you to be able to understand. Okay. So for the cyst, we do. How would you treat the cyst? Simple cyst, how would you treat it?
Drainage and the ultrasound guidance?
No. I put the ultrasound guidance, but that doesn't mean this is the management. What is the management for simple cyst? No. This is one of the mistakes in the exam. Fine needle aspiration is a tissue biopsy, is not a fluid aspiration. So FNA is a fine needle aspiration. The meaning of it is tissue diagnosis, tissue biopsy, is not a fluid. When we do it, we put the tissue in slide and send it for pathology to read it. My question is, how would you manage simple cyst?
Follow up for 6 months.
Follow up every 6 months, not for 6 months. Every 6 months. Reassure the patient. We will do the examination, physical examination, ultrasound every 6 months, like the fibroadenoma. But what is the difference? There are some indication for aspiration. And when we say aspiration, it's ultrasound guide aspiration, not FNA. So what are the indication for ultrasound guide aspiration?
If the patient is symptomatic.
If the patient is?
Symptomatic.
Symptomatic, صح. Great, excellent. So she has pain. What else?
If there is blood in the fluid.
How can I know this is blood?
After I aspirate.
So what I said, what is the indication for aspiration? You know it's bloody after aspiration. I'm asking you why, when should I aspirate?
When the patient is symptomatic or having symptoms.
So number one, symptomatic. Agree. Number two.
If it grows too large.
Complex cyst.
Yes, complex or complicated cyst. Ask them, what should you do? So what is complicated or complex cyst?
So it won't appear on the ultrasound like a simple cyst. It's going to be cloudy or.
Yes. So this is
very close.
Yeah. Okay. So this is simple cyst. It's really very clear border, hypoechoic and acoustic shadow, nothing there. But if this cyst become irregular, or there is some microcalcification, or there is septation inside, or there is some solid component, we need to do aspiration, and for solid component we need to do biopsy. Clear?
Yes, everything's clear.
Everybody clear?
Can you repeat that?
Okay. So for simple cyst, we will just reassure the patient. Observe here every 6 months. We will repeat the ultrasound and physical examination. However, we need to aspirate. What do I mean by aspirate? Ultrasound guide aspiration to aspirate the fluid if the patient is symptomatic, or if the cyst character or features in the ultrasound change from simple to complex or complicated. So what do I mean by complex or complicated? I mean the cyst is not smooth anymore. So there will be an irregular border, or there is microcalcification, or there is septation, or there is a solid component inside the cyst. In this case, I need to aspirate, and if there is a solid component, I need to take a biopsy, through cut biopsy. Clear?
Yes.
Clear for everybody? If you want me to repeat, let me know, because I know not all of you attend with me, so I'm not quite sure if you know it or somebody explain it to you. Okay, so if we aspirate, as you can see here in the picture, the fluid should be serous, and this is the usual of the cyst. And we will send this fluid for culture and for cytology. This is mandatory. If we aspirate, we need to send this fluid for cytology to rule out malignancy or atypia, and culture to rule out infection. Clear?
Yes.
Yes, doctor.
So, okay. So number one, observation. Number two, there is some indication for aspiration. Let's go to number three. There are some indication for surgical removal. So when should I remove the cyst surgically?
If
We
the
have
aspiration,
atypical sim.
Yes, excellent. So one of the indication, if we aspirate, send it for cytology, it was positive for atypia. What else? Or malignancy?
blood.
Bloody aspiration. Excellent. This is another indication for surgical removal. Number three.
Do it 2 times aspiration and then recurrent.
Yes. So if you aspirate twice and the cyst recur for the third time, we need to remove it surgically. Clear?
Yes.
So I will just go quickly. Fibroadenoma is a solid mass, so there is no aspiration. It's either observation or surgical intervention. Cyst is a fluid, so we have 3 options: either observation or aspiration, and you need to know the indication for aspiration, or surgical removal, and you need to know when should you remove it surgically. Clear? Let's go to next. If you have question, raise your hand or ask. I need somebody to comment about the photos. What can you see in the photo? Because in the exam, we can bring something and ask you to describe it or tell us what can you see. So anybody?
Doctor, I think there's inflammation and erythema.
There is erythema, okay. Let's focus in the one with the huge red breast in the right, I think, in the left.
Yeah. Is it ischemia?
Ischemia is blue. This is redness. So the description, there is swelling and redness or erythema of the right breast. We are speaking about this. صح? What else can you see in this photo?
Mass on the upper, I think upper outer quadrant.
I cannot see a mass. You mean this one? I cannot see it. I cannot tell if this is a mass or this is hair breast. But what can I see?
Doctor, where is the nipple?
Yes, we cannot see the nipple. Does that mean the nipple is inverted?
I don't know. There is some faint, small, tiny bulging in the lower portion of the breast. I'm not sure if this is the nipple. Yes, it's on the right side of the mouth. This one.
Yeah, yes. And I will tell you how would you describe this photo. I will say there is a swollen redness and erythema or redness of the right breast. I cannot see the nipple. It could be inverted. The nipple could be inverted. It could be down. Actually, if the patient in front of you, you need to raise the breast up and see. It could be this is the nipple. It could be down. But in this photo, I will just say I cannot see the nipple. That's it. Could be inverted or down. Okay. How about this breast here? What can you see? Again, there is some redness here, but in this photo, the redness is more localized. Here is generalized. Anyway, either this or this. If you have redness, hotness, of swelling of the breast, what are the differential diagnoses?
It was basically the signs of inflammation.
Mastitis.
One of them is mastitis. What else? Redness, hotness, swelling. Inflammatory breast cancer. What else?
Abscess.
Excellent. Abscess. So they are the most common.
And we said abscess, we do ultrasound.
I didn't speak yet. I didn't ask you what should you do. Let us go one by one. So the differential diagnosis is either mastitis or abscess or inflammatory breast cancer. It could be any dermatological disease, but this is the differential diagnosis. In this case, how would you manage this case? What should you do?
Triple assessment.
Yes, this is what I want to hear in the exam. Don't jump to the imaging. Triple assessment. Number 1 is history and physical. Number 2 is imaging and labs. Number 3 is the biopsy. So number 1, physical, history first. You have to ask all the history to rule out infection, cancer, dermatological condition, or mastitis. Okay? In the examination, what should you examine?
Four quadrants of the breast and the axillary lymph nodes?
No. What I teach the group, you need to do 4-step examination. What are the 4 steps?
Vital signs.
Vital signs.
Then
Vital
general
signs
exam.
is important. Why? If it is infection or inflammation or even inflammatory breast cancer, patient may have a fever. If it is dermatitis, patient may not have a fever. So number 1 is vital signs. And if there is any fever or patient is reacting very bad, we have to rule out septic shock and we have to treat her as an emergency case. So vital signs, number 1. Number 2?
General exam.
Excellent. So number 2 is general exam. Number 3?
Local.
Local exam. Excellent. So local exam including what? Breast and lymph node. Lymph node, how many areas or groups do you need to examine when you examine the breast? I'm speaking about lymph nodes. How many groups of lymph nodes or how many areas?
5. Lymph nodes 5.
Listen carefully. I said how many area or groups do you need to examine? I didn't ask you how many groups in the axilla.
2. One in the breast and one in the axilla, right?
We need to examine the axilla. We need to examine the supraclav. We need to examine the parasternal or internal memory. So there are 3. There are 3 areas you have to look for lymph node in them. But if I ask you how many groups in the axilla, they are
5.
5. What are they?
Medial, lateral, and anterior, posterior, and apical.
Okay, so I'm not quite sure who was speaking with me. Is it clear for you? When we ask you how many areas do you need to examine to complete your breast examination, there are 3. Axilla, supraclav, and parasternal or internal memory. When we ask you how many groups in the axilla, They are 5. If I ask you how many levels of the axilla?
3.
Excellent. Based on what?
Based on the pectoralis minor.
Great. Clear for everybody?
Thick minor tendon.
Yes. Excellent. Okay, so we said number 1, vital signs. Number 2, general examination. Number 3, local examination. In breast, it will be the breast and the lymph node. Number 4, systemic examination. Clear for everybody?
Doctor, is it
Doctor,
okay
what
if
do you
you
mean by
repeat
systemic?
So one by one, I cannot hear you, huh?
Can you please repeat for the lymph node groups? When do we say 3? When do we say 5?
Yes. If I ask you how many areas or group do you need to examine to complete your breast examination, you should tell me 3. The axilla, the supraclav, and the parasternal group. If I ask you how many groups in the axilla, 5. If I ask you how many levels of the axilla, they are 3. If you are speaking about physical examination, we use the groups. We don't use the level. Level is for the surgeon when he do the surgery, because we will go under the pectoralis minor. But clinical examination, you cannot go medial and lateral and behind the pectoralis. You will use the axillary groups, the 5 groups. Clear?
Yes, thank you, doctor.
There was another doctor, he have another question. I didn't hear you. Can you repeat your question, please?
Sure, doctor. So we have, we said we have 3 exams, right? General, local, and systemic. What's the difference between the systemic and general?
We have 4, not 3, Osama. 4. Number 1, vital signs. Number 2, general examination. Generally, is the patient conscious, alert, she is in pain, she is not in pain. And number 3, local whole breast and the lymph nodes. Number 4 is systemic. Systemic, that means you have to examine the chest, the cardiovascular, the abdomen, the neurological, the musculoskeletal. Clear?
Yes, thank you so much.
If it's not clear, let me know. I will repeat it, Osama. I know that some group, they didn't take with me, so that's why I'm giving the lecture.
Thank you so much. Everything's clear now.
Okay. Let us go for our differential diagnosis. If this is a mastitis, how would you treat the patient?
Antibiotics?
Yes, so we will treat it with antibiotic. But before is there anything we have to do? احنا قلنا triple assessment. Triple assessment, we finish history, physical examination. What is next?
We do imaging and we do biopsy to send it to cytology.
Okay, so imaging. The standard is mammogram. Do we need to do mammogram in mastitis or abscess?
No, it's not an indication.
Enough.
We will do the ultrasound. It's not enough. We will start with ultrasound. Why should we start with ultrasound? Because it's painful and we need to rule out abscess or mastitis. Abscess or mastitis, the treatment is antibiotic or incision and drainage. But mammogram, we can do it later. So the urgency now is to rule out the infection first. So we will do the ultrasound now to diagnose the patient either with mastitis or with abscess and then treat her. Later on, we will do the mammogram. She will not be able to go for mammogram with abscess or with mastitis. It will be very painful. Clear?
Yes, doctor.
So what is the standard? Doctor? Yes.
Sorry for interrupting. So we treat the abscess with incision and drainage, and we treat the mastitis with antibiotics only?
Antibiotics, and sometimes we will give them painkiller. It's painful, so sometimes we'll give them painkiller. Generally speaking, the patient, she may have some hot or cold compression, but I don't ask for it because sometimes they will burn themselves. But it will be very helpful, for example, if she's breastfeeding, to decrease the milk engorgement. They will respond very well to the painkiller and the antibiotic. Okay?
Okay, thank you.
Okay. Should I do biopsy in abscess and mastitis?
Can you please repeat the question?
Now we have a triple assessment. We are finished from the physical examination history. We finished from the imaging. Do I need to do biopsy to diagnose or to treat the mastitis and abscess?
Do we do instead an ultrasound guided biopsy to see if it's what bacteria or what microorganism is causing it to do the antibiotic specific for the bacteria?
This is for which one? You mean the mastitis or the abscess?
And mastitis.
No, we don't do that. For mastitis, we'll treat the patient with antibiotic without doing anything. If there is a discharge, I will take a culture from the discharge and send it for culture. But I never take a biopsy from mastitis, except if there is a mass and we treat the patient with antibiotic, she didn't respond, we will do biopsy from the mass to rule out cancer. Or to rule out granuloma, which sometimes we call it granulomatous mastitis. But there is no indication for any kind of biopsy if there is no mass. Clear?
Clear.
So the only indication for biopsy in mastitis if there is a mass in the ultrasound. So we treat the abscess with incision and drainage. Incision and drainage, actually, it could be surgical, it could be ultrasound guide aspiration. So we don't really need to open surgically to treat the abscess. Sometimes ultrasound guide aspiration is more than enough, but we need to drain the abscess. And for mastitis, we treat it with antibiotic. In some cases, we need to give them some extra, for example, steroid, or see what is the underlying reason to develop mastitis. Usually it is bacterial, but it could be something else. It could be something related to the connective tissue disease. It could be hematoma or trauma. So whatever the reason behind it, we can treat it. How about the inflammatory breast cancer? If this is an inflammatory breast cancer, how would you manage her?
Chemotherapy followed by a mastectomy.
Yes. So all the inflammatory breast cancer, they need to receive new adjuvant chemotherapy followed by modified radical mastectomy. What does modified radical mastectomy mean? Removing the breast and axillary lymph node dissection.
Doctor, can you please repeat the treatment?
For the inflammatory breast cancer, all the patients with inflammatory breast cancer, they need to receive new adjuvant chemotherapy. And after they finish from the new adjuvant chemotherapy, they will go for modified radical mastectomy. What does modified radical mastectomy mean? We have to remove the whole breast tissue and we have to do axillary dissection. Axillary dissection for level 1 and 2. This is the standard. Clear? Or should I repeat?
Clear.
Clear, doctor.
Okay, so let's go for next. Anybody? Can you describe your finding in the imaging? This is the nipple, by the way.
Is it Paget's disease of the nipple?
Did I ask you what is the diagnosis? I say describe your finding.
Scaling.
Feeling, okay. Scaling lesions, ممكن ulceration. Then I will ask you what is your differential diagnosis? What are the differential diagnoses?
Paget disease is one of the differentials.
Yes, excellent. One of them is Paget disease. What else?
Dermatitis.
Dermatitis, excellent. What else? Psoriasis, eczema, okay?
Infection.
Infection unlikely, but maybe I will say okay, yes, it could be, but unlikely. And infection usually come with erythema, hotness, redness, not only scaling. Okay, so how would you manage this patient?
Punch biopsy.
No.
Triple assessment.
Triple assessment. Yes, this is what I want to hear. You have to tell me triple assessment. So we'll go for history and physical. We will go to imaging and labs, and then we'll go for biopsy. History is important because if this patient has any kind of psoriasis or eczema or dermatological problem, this will help me to know that this is the case. But if she have nothing, I have to be careful and think about budget disease in more careful way. Okay, so what do you want to do in form of images?
A mammogram if she's more than 30.
Yes, or ultrasound if she's less than 30. If the ultrasound and or mammogram, they are negative.
Resect.
I didn't get what?
Resect the mass.
Where is the mass? I said the mammogram and the ultrasound are negative. Negative, there is no mass. So resect what?
The breast mastectomy.
I didn't get it.
I think radical mastectomy.
Before radical mastectomy, we need to do MRI. MRI breast. And if the MRI breast is negative, what should we do next?
Punch biopsy.
Punch biopsy. What do you mean by punch biopsy?
It's we're just taking a surface biopsy of the nipple tissue.
Yes. So it is some kind of dermatological biopsy. They take biopsy from the skin. This time we'll take the punch biopsy from the nipple to rule out budget disease. So if they say this is budget disease, we'll treat the patient as a budget disease. If they say this is eczema, so this is eczema. Treatment of eczema is steroid or whatever local cream or ointment described by the dermatologist. But if this is a budget disease, how would you manage? There is no mass in the breast.
It's radical mastectomy as well.
What is it? I didn't hear you.
I said radical mastectomy.
What do you mean by radical mastectomy?
Remove
as well of what? I didn't get it. Did I say radical mastectomy before?
Yes, we said for the. Sorry, I forget.
For the inflammatory breast cancer, we said modified radical mastectomy. I didn't say radical.
Yes.
So in inflammatory breast cancer, we do modified radical mastectomy, and in budget, we do radical mastectomy.
We do breast conserving surgery.
What do you mean by breast conservative surgery?
It's practically like a lumpectomy, so it's a partial mastectomy.
Okay, so none of the answers are correct. For the inflammatory breast cancer, we do modified radical mastectomy, and modified radical mastectomy means removing of the breast and dissect the axillary lymph node level 1 and 2. For the budget disease, if it's completely negative imaging, we do simple mastectomy or skin sparing mastectomy, and we take a biopsy from the lymph node. We call it sentinel lymph node biopsy, and we do immediate reconstruction. That's let us, before I go, I want you to be with me to understand what we are doing and what I'm saying. How many types of mastectomy do you know? By the way, we ask this in the OSCE exam. How many?
3.
What are they?
Simple mastectomy, modified radical.
One by one. What is the simple mastectomy?
It's removal of the breast tissue.
Excellent. Number 2.
Modified radical mastectomy.
What do you mean by modified radical mastectomy?
We remove the breast tissue and level 1 and 2 if the imaging shows metastasis to them.
Excellent. Number 3.
Number 3, radical mastectomy.
What is radical mastectomy?
Everything removed.
What is everything?
Breast tissue, lymph nodes.
Including the muscle.
Including the muscle, the nerves, and sometimes even the vein. This is the radical mastectomy, and we are not doing it anymore. Except in very, very, very rare cases or exception. But the standard, no more radical mastectomy. Radical mastectomy will cause a lot of complication. Patient may die from it with no benefit from the disease survival. So nobody is doing the radical mastectomy anymore. We are doing either simple mastectomy or modified radical mastectomy. Is there any more kind of mastectomy? Yes. Simple mastectomy, we remove everything, the nipple, the skin, and the breast tissue. If we spare the nipple and the skin, we call it nipple sparing mastectomy. If we spare the skin, we call it skin sparing mastectomy. If we remove the skin, this is simple mastectomy. If we remove the breast tissue, the skin, nipple, and the axilla lymph node level 1 and 2, this is modified radical mastectomy. Clear, or should I repeat it?
Clear.
For everybody, clear?
Doctor, what about the conserving mastectomy, which is the lumpectomy? Yeah.
Lumpectomy is not. We can use it.
No, I mean the conservative.
Yeah, the conservative is what when we say conservative, that's mean we will do lumpectomy with radiation therapy, plus minus axilla. But it's not indicated in budget disease because budget disease is involving the nipple. We cannot spare the nipple. We have to remove the whole breast. We can do the lumpectomy when we have a small lump and it's not central. It's not involving the nipple. It's not involving the skin. So we can do lumpectomy in breast cases, breast cancer, if the mass is small, the mass is not retroareolar, the mass is not attached to the skin or to the muscle. Clear?
Clear.
And if we proceed with lumpectomy, this patient needs to receive radiation therapy. It is mandatory. So if the patient, for example, cannot take the radiation or she is refusing the radiation post-op, lumpectomy is not the best management or option to offer to the patient. Now we are speaking about the budget disease. Although there is no mass, but the budget disease is involving the central area, the retroareolar nipple complex. So in this case, we need to remove the whole breast. We can save the skin, but we have to remove the nipple and the breast tissue. We can do reconstruction, yes, we can. We will put implant or whatever for her, but by the end, we have to remove the whole breast tissue and the nipple areolar complex. Usually those patients, they don't have lymph node by clinical examination or by imaging. So we will do sentinel lymph node biopsy. We biopsy the lymph node intraoperatively. We send it for the pathology as a frozen section. And if they told us it's negative, we will not do anything. But if they said it's positive, we have to do axillary dissection. Clear?
So what's the name of the procedure for removal of this breast tissue?
Removal the breast alone with the nipple is simple mastectomy. We remove the breast and the nipple with extra skin. So
we do a simple. We do a simple mastectomy.
Yes, and sentinel lymph node biopsy. If the center have plastic surgery like King Faisal, we do skin sparing mastectomy and sentinel lymph node biopsy. Skin sparing, that's mean we can do reconstruction. We will put implants.
Okay.
Okay. Clear for everybody? Clear? Can I go for next?
Yes, doctor.
Okay. Can anybody describe what can he see in the image?
Nipple discharge.
Bleeding.
Nipple discharge what?
Bleeding nipple.
ما هي bleeding. اسمها bloody discharge from the nipple. Bloody discharge from the nipple. Most likely it looks single, but you cannot tell. I will show you the other one. This is also a bloody discharge. Can you see the one down?
Yes, doctor.
So the one down is clear. It's multiple duct. Here, most likely the upper one is single duct. The one down is multiple duct. But all of them, they are bloody discharge. So what is the most common cause for bloody discharge?
Intraductal papilloma.
Yes, and this is benign or cancer?
Benign.
Benign.
Yeah, benign.
If this patient is in your clinic, how would you approach the patient?
Triple assessment.
In every single case, we show you history, we give you scenario, we show you image. You should tell me, I will do my triple assessment. And what are the triple assessment? You know what are they. In this case, the most common cause we say is intraductal papilloma. What is the second most common cause?
Papillary carcinoma, intrapapillary carcinoma.
Intrapapillary carcinoma is similar to the intraductal. What is the most?
Fibroadenoma?
No. Breast cancer, invasive ductal carcinoma. So the most common diagnosis is benign, intraductal papilloma. But the second most common is cancer, breast cancer. We will do our triple assessment, and if there is a mass, we will take the biopsy. Biopsy shows intraductal papilloma, this is benign. It shows cancer, so we should treat the patient as a cancer. What is the treatment for intraductal papilloma?
Surgery?
We don't interfere surgically. If the patient has a mild symptoms, just observation. If she has continuous discharge, we will excise the duct. If there is any mass, we will remove the mass. Clear?
Can you repeat, doctor, please?
If she has a mild, on and off discharge, we will just observe her, examine her, and follow up her in regular basis. If there is continuous discharge, we have two options. If there is a mass, we will excise the mass. If there is a duct like here, we will just excise the duct. So either removing of the duct, which has the discharge, or if there is really a mass, we will go and remove the mass. Okay? Most likely in your exam, they may bring the option of excising the ducts. Okay?
Yes, doctor. Okay, thank you.
This is benign, and the only reason that we are removing the duct because she is symptomatic. She has bloody discharge. But if this is the cancer, we'll treat the patient as a cancer. Okay.
I have a question, doctor, regarding the previous case.
Okay, I will go back. What is your question?
Thank you so much. So do we do a biopsy in this situation?
If there is a mass, yes. For sure you have
Only if there is a mass.
Yes. But if there is no mass, but she has discharge, we will excise the duct. Clear?
So, yes, clear. So one more question about the imaging. So do we need to do any, for example, ultrasound or something? Or
you have to do triple assessment in every single case. This case, you will do the triple assessment. Based on the age, you will go
kind of
with
imaging?
Based on the age.
Depends
what did
on
I
the
say,
age.
Osama?
Yeah, okay.
What did I say? Repeat. What is the standard?
So we have, the standard is mammogram if she is above 30. If she is below 30, we do ultrasound because of the breast is very dense.
Yes.
And also the pregnancy.
we will do a mammogram is good for all ladies with less dense breasts, but the ultrasound is good in young ladies with dense breasts. Mammogram, the idea of the mammogram that the breast tissue will change with aging and it will be replaced with more fat, so it will be good in old ladies. But young ladies, they have more dense breasts, so you cannot really able to see anything in the breast. But that doesn't mean صراحة it's only depending on the age. Sometimes we have ladies with 40, 50s and still they have a dense breast. So the density of the breast also is an issue. But for your exam, use the age. The cut line is 30. So below 30 ultrasound, above 30 mammogram. Okay?
Okay, thank you so much.
Yeah, this is coming in your exam. So somebody, can you tell me what can you see?
So first of all, we have to say that we're seeing a mammogram here.
Yes. So the first thing in the exam, you should tell me this is a mammogram. Excellent. So how would you read the mammogram? Do you know how to read it? Well, should I read it for you? Then you will comment after me.
Yes, sure, doctor.
Right. For the mammogram, you need to be very, very systematic. Otherwise, you will forget some of the findings. So when we read the mammogram, here, can you see this line? This is the skin. Okay? So the first thing, when you read the mammogram, tell me this is a mammogram, then comment about the skin. Here, the skin is okay. However, the skin here, you can see the white line. This is thick skin. So there are some thickness in the lower part of the mammogram. This is the first thing to be read. Second thing, after the skin, you have to comment about the nipple. In this mammogram, I will say I cannot see the nipple. It could be inverted, but it could be also in other image. I didn't give you the rest of the imaging. So this one shows no nipple, which could be inverted, or it will be present in the other imaging. After the skin and the nipple, we will go for the breast tissue. You can see the breast tissue here. If this breast tissue has a lot of white hyperdense tissue, that means this is a dense breast. So this one is dense breast, a lot of white. If it is really more to the black, it's a regular or normal dense breast. Here, this is dense breast. Okay? So we'll comment about the skin, nipple, then the breast tissue itself. Then we will see if there is any finding here. So what can I see here? Yes, I can see some micro calcification. This. Then I see a mass. You have to describe the mass. So in this image, what can I see? This is really hyperdense. When you read the mammogram, you can describe it as hyper, iso, or hypodense. The white is hyperdense. So there is a mass, hyperdense mass, most likely in the lower part of the breast, but you cannot tell me exactly is it inner or outer because I didn't give you another image. I gave you one image. The only thing that you tell me that this is in the lower part of the breast, hyperdense, and it's irregular. The irregularity is not based on only shape. Here, some of you will say this is a circle one. Yes, but see the density. Density is not all the same. So the density is irregular. This is irregular mass. So we have a mass, hyperdense, irregular in the lower part of the breast, roughly, and I remove the scale because if I put the scale, you have to measure it in correct way. So I remove the scale. You can give me an assumption. So you will tell me 2 by 2 centimeter, 2 by 3 centimeter, 3 by 4 centimeter. This is all acceptable. But I don't want to hear in the exam 20 centimeter or half centimeter. Clear? Are you with me?
Yes.
Okay,
Yes,
so
doctor.
where is the lady who she was volunteering to read the mammogram?
Yes, doctor.
Can you read it?
Oh, okay. So first of all, you're going to say that it's a mammogram, and then
Yes.
you're going to look at the skin first. you're going to see that it's thin all over, and then down it's thick.
I will not say thin. I will say normal skin with thickness in the lower part.
Yeah.
Okay.
And then you're going to look for the nipple. So you can't see it here, but it's either inverted or you can't see it because of the image.
Okay.
Then you're going to look for the breast tissue. You're going to see the, it's hyperdense, not like a dense tissue, not a fatty tissue. And then you're going to describe the mass. So we're going to say that it's a hyperdense mass, about 2 by 3 centimeters. Then you're going to describe the location. So it's in the, without the lateral image, we can't tell. And then we're going to say the mass is regular or not regular. So it's irregular because of the color.
Don't say the color. In the exam, just say irregular. And I'm explaining to you. In the exams, just say irregular hyperdense mass in the lower part of the breast. Okay, then?
Then we're going to comment about the microcalcifications.
The size?
And we can't see them here. And the size, yeah, we comment like it's not 20 or 2 millimeters. We're going to say it's like 2 by 3 or
yes.
3 by 4.
Okay. And there is a microcalcification. Clear?
Yeah.
Good job.
Yes.
Excellent. Anybody else want to read it again?
Doctor, how do you want to calculate the size? It's a bit confusing for me.
A size roughly 2 by 3 centimeter. That's it. I will accept it.
Okay.
In reality, we have a scale. And the scale, you can use it to measure. So usually the scale, it will be somewhere here or here. And it will tell you this is 1 centimeter, 2 millimeter. It will divide it based on the image. So some of them, they will give you, for example, the 1 centimeter with 5 dashes. Every dash will be equal to 2 millimeter. Some of them, no, they will give you 10 dashes. So every dash mean 1 millimeter. The scale is different from one machine to another one. But if we put it and you get it, you didn't calculate it correctly, you may lose some mark. So we don't put it, but roughly this is the breast. So if you say 2, 3, 4 centimeter is acceptable. But don't tell me something unbelievable, something like 20 centimeter. If this is 20 centimeter, you have to prove it for me. Or half centimeter, you have to prove it also for me. You get it? So in the exam, if you say something around 2 to 3, 3 by 3 centimeter, 3 by 4 maximum is acceptable. Clear? Anybody want to read the mammogram again? Osama, read the mammogram.
Okay, so mammogram, so as you said, we go by the type of image, which is mammogram. Then we examine the nipple and the skin surrounding it. Then we look at the breast tissue. So here we have a hyperdense, irregular mass measuring 2 by 2 or 2 by 3. And we can see some microcalcifications scattered in the breast.
This is very important. Okay, thank you, Osama. Excellent. How to read the mammogram is very important, and most likely it's coming in your OSCE exam. Okay, clear for everybody? If anybody have any question is not clear, please ask. Okay, so let us go to the next slide. I don't know, Tala, are you with us, Tala? Well, no, Tala maybe one of the
Yes.
Tala, can you read the mammogram?
So we're looking at a mammogram.
This one. Don't read this one. Read this one.
Okay. The skin is kind of irregular. And
okay, good, excellent. So this is thick here. This is thick. Can you see the white?
Yes, so on the lower part.
Yes, here normal, here thick. Okay.
I also can't see the nipple, so it could be inverted or it could be in other images.
Excellent.
Then I will move to the tissue. So the breast tissue is white, so it's a dense breast, most probably.
Okay.
Is the upper arrow pointing to calcifications?
This is a mass, by the way. And this is the difficulty of finding the mass in this breast. That's why young ladies, ultrasound is better. You may not be able to see it, but because I'm familiar with the imaging, I know this is a mass. Okay, but don't worry, in the exam, I will not bring something like that. I will bring something clear like the previous one. And for you also, this is a lymph node, but we don't bring this image. I bring the other view without the lymph node. I don't want to confuse you in the exam. So if I bring in the exam image, it will be like this. Clear?
Clear, doctor. Thank you.
Thank you, Tala. Excellent. Well
Yes,
done.
doctor.
Okay. Next, let's see if I want to ask somebody. Hani? No, Hani, are you with us?
Yes, doctor.
I'm not quite sure. Hani, are you a student?
Yes, I am the leader.
Okay, Hani, describe what can you see?
Okay, I can see a scar. Surgical.
Scar of what?
Of probably a mastectomy.
Mastectomy. Wallah, you are clever, smart, ya Hani. Hani, what kind of mastectomy? Yes, this is mastectomy, but you didn't tell me what type of mastectomy. You are smart, you said mastectomy, but in the exam, I want an answer. What type of mastectomy?
Not quite sure. Probably a simple mastectomy. Not quite sure, honestly.
Okay. This photo is for mastectomy. Before I go further, Hani, we said there are multiple types of mastectomy. Number one is simple mastectomy. We will remove the breast tissue, nipple, areolar complex. صح? So this one could be simple mastectomy. You are right. You are absolutely right. Number two, modified radical mastectomy. We will remove the breast nipple tissue and we will clear the axilla. We can use this scar to do it. So this scar could be simple mastectomy. If you said simple mastectomy, you are absolutely correct. If somebody said modified radical mastectomy, he is or she is also correct. But if somebody said this is radical mastectomy, he or she will be wrong. Why?
Because we can see the muscle.
Because what?
We can see the muscle.
Yes, the muscle is there. There is no depression. See the chest wall, bilateral, they are the same. If this is radical mastectomy, that means we will remove the muscle. So there will be a depression in the chest wall and you can see the ribs just behind the skin. Clear?
Yes, doctor.
In the same time, this is not skin sparing mastectomy because there is no implant. We didn't do any reconstruction. This is not nipple sparing because we didn't spare the nipple. In your level, we don't ask about skin sparing and nipple sparing because it's really difficult for you to know what. We are focusing on simple mastectomy, modified radical mastectomy, and radical. Okay, so thank you so much, Hani. Let us go to Rakan. Rakan.
Yes, doctor.
What are the complications of mastectomy?
We could damage nerves.
What are the nerves?
We have long thoracic.
Long thoracic, and if you have long thoracic injury, what do you have?
Winged scapula.
Okay, excellent. What is the other nerve? Thoracodorsal, and thoracodorsal injury will cause abnormality in the shoulder abduction. So one of the complications is the nerve injury. What else? Yes, excellent. So like either any other surgery. What are the complications of any surgery?
Infection. Hematoma.
Infection,
anesthesia
bleeding,
complications.
Yes, anesthesia complication, wound infection, wound healing problem. So this is all can happen in every single case. So remember it for any case, not only for the breast. When they ask you about complication, save the time until you think and say bleeding, infection, wound heal problem, and then hematoma, specific for mastectomy, nerve injury like long thoracic nerve, winging scapula, or thoracodorsal nerve injury, and it will cause abnormal shoulder abduction, and lymph edema if there is an axillary dissection. Lymphedema, it will be a swollen in the hand due to lymphatic obstruction. Clear?
Yes, doctor.
Okay, so next. I want Dr. Muhammad Yaman, I think.
Winging scapula.
Yeah, okay, winging scapula. This is very important in the exam. So this is winging scapula. Due to what?
Due to long thoracic nerve injury.
Injury. And when the long thoracic injury, the nerve injury will cause what? Which muscle will be affected?
Serratus anterior.
Excellent. Okay, yeah. Let's go to this. Please be awake, all of you.
Mama,
Yamil.
is your camera open?
No, it's closed.
Why do you always keep it closed?
Because I don't need it. I have my presentation. I'm waiting for the video to be opened. This is very important for you because in the exam we have a dummy. I know that you didn't see any dummy, but I will show you how the dummy will look like and what are the possible findings and how would you examine them.
Why is it here?
Is it my connection? يعني ويك ولا إيش؟
This is for Baba. What the? Mama.
Yes.
Did you know when you're sleeping, Baba's awake?
Can you see the video now? شكلك قفلت اللي فتح.
No, I can't.
Mishari, be careful, Mama. Be quiet.
Don't see it.
See, I have all the other students. They want to watch. So
Wait.
Be quiet. Be quiet, Mama.
Wait, you're the teacher?
Yes.
Why?
My name is Cameron Hubble, and today we're going to study breast examination.
Can you see it? Clear or should I? I want.
Yes, doctor, we can see it.
A lot of other things.
I know this.
Mishari, be quiet, Mom.
Perform on the mannequin that we.
The video is lagging, doctor. Can you rephrase it?
Give me a second. I will make it more clear and I will make the voice louder. But just give me a second to fix it. I think it's now very loud. And I will start from the beginning. Please watch it carefully.
And today we're going to study breast examination on a mannequin. During the process of this examination, I would be speaking aloud a lot of other things as well, because there's some limitations of examination that we cannot perform on the mannequin that we would be doing in real life on a patient. So starting off with when you go in the room, so I'll be walking you through it. You go in the room, you see a patient, and you have to perform a breast examination. You first of all introduce yourself, greet the patient, and confirm the identity of the patient. After you've done all that, you need to tell the patient why you're there. You need to examine the breast of that patient, and then take the consent after explaining what you're going to do. After the patient has consented, you have to make sure that there's someone with you while you perform the examination. You have to ensure the privacy of the patient. If you are in a hospital setting, it can be a nurse or any other staff who can come along with you in the examination. If it is an OSCE station and you're doing it as a part of an exam, what you can do is that you can make a statement by saying, I will ensure the privacy of the patient by asking the examiner to be the chaperone. You do not need to ask the examiner to be the chaperone. You can just make a statement that you'd like the examiner to be the chaperone so that they know that you've ensured the privacy of the patient before the breast examination. So first of all, we need to do inspection of the patient. And before that, we need to ask the patient to adequately expose. So after adequately exposing the patient, we need to look and inspect the patient. So in this, considering that this is a patient, we can see that there's some discharge coming out of the right nipple. There's some redness on the right side of the breast. There's no obvious swellings. There's no scar marks, no sinuses. I can also appreciate some orange peel-like skin on the left side. And I can also appreciate an inverted nipple on the left side. So that's my inspection. But in real life, you also have to make certain positions in which you will be inspecting the patient. So what you're going to do with the patient in real life would be, you'd be asking him to place her hands on the waist and asking her to squeeze, and then check for obvious masses in that position. After that, you're going to ask the patient to bend forward a bit and see if there are any masses obvious in that position. Then you're going to ask the patient to place their hands behind the head like this and see if there are any obvious masses or if there's any axillary fullness. And then the last two things that you have to do is to ask the patient to lift her breasts to look for any inframammary eczema, and also to squeeze the nipples to see for any discharge or bleeding. On palpation, when the patient's properly exposed, what you're going to first of all do is to check for temperature and check for the relevant quadrants on both sides. So there's no increased temperature on either side of my patient. After checking the temperature, just look for the comfort of the patient continuously during this examination and talk to the patient by telling her, please let me know if you feel any discomfort or pain, and I'll stop right there. And also tell me, I'll be touching you gently now, and let me know if you feel any pain. Go in an anti-clockwise manner. I'm doing the superficial palpation at the moment. And there are no obvious masses on superficial palpation. Look at the patient's face. Make sure that they're comfortable. So that's the superficial palpation of both breasts. After that, tell the patient that I'll be touching a bit deeply now. Please let me know if you feel any discomfort or pain, and I'll stop right there. So yes, I can feel a mass in the left outer quadrant, the left upper quadrant of the left breast, which is about 2 centimeters into 2 centimeters in size. It is smooth. It has a smooth surface. It's got a regular shape. It's attached to the underlying structures. It is not attached to the overlying skin. And it is very hard in consistency. After that, complete the deep examination and keep on looking at the patient. After doing the deep palpation, palpate the areola. So this is called periareolar palpation. Use your thumb and move around the nipple, but do not touch the nipple itself. So there are no obvious masses, any periareolar masses palpable. Now you have to do the same on the right side, anti-clockwise, deep palpation, check for the comfort of the patient. And then periareolar palpation. So there are no obvious masses on this side. So After you're done with the palpation, what you do is you check for the lymph nodes. You cannot check for lymph nodes in a mannequin properly, but there might be findings in mannequins. So the lymph nodes that we need to check are the axillary lymph nodes and the supraclavicular lymph nodes. So we need to check the anterior, the medial, and the apical lymph nodes. Now, in a real patient, you need to check these while the patient is standing, and you have to place one arm on the patient's arm, and the patient puts his arm on your arm, by which you'll be palpating the lymph nodes. You can also look into my lymphoreticular examinations, how a lymph node examination is done on a real patient. So you need to check for the anterior, medial, and apical set of lymph nodes anteriorly, and from the back of the patient, you have to check for the posterior and the lateral set of lymph nodes. Also, just ask the patient to shrug the shoulders and have a feel of the supraclavicular lymph nodes. After you're done with the examination, thank the patient, cover the patient, and talk to the examiner. If the examiner asks for differential diagnosis, you can obviously say breast cancer, a cyst, fibroadenoma, and fat necrosis. So there are multiple differentials that you can tell the examiner. And this is how you examine the breast of a patient, ensure the privacy, do a thorough examination. Remember always to do a superficial palpation, deep palpation, and periareolar palpation, and end the examination by checking for the lymph nodes. I hope this was helpful, and I hope you enjoyed as well.
Is it clear?
Yeah. Can I tell you something?
Is it clear?
Yes. But can I ask one small question, please?
Yes.
Do we do the examination without the gloves?
And you have two options. Either you wear your gloves or you have to wash your hand, one of them. If you have laceration or any injury or a wound in the hand, it's a must to wear gloves. So either way, to save the time, I prefer, this is me, but it's up to you, I prefer to wear gloves. If you didn't wear, you have to show me that you wash your hand, you dry, then you examine the patient. And by the end, you have to wash your hand again. But if you wear the gloves, you will wear it, examine the patient, and throw the gloves. Clear?
Yes, thank you, doctor.
Is it clear for all of you? Because this is what is in the exam. Your dummy is almost similar to this.
Doctor, can you talk about what to comment on when we feel the mass? Like he mentioned, you comment on the size, and you comment if it's attached to the outer skin or like the inner. Can you comment on like the full criteria we should talk about in the exam?
Exactly as he said. Top. And you didn't watch him?
I did, but so we say everything he said exactly, or should we?
Yes. What is the most important point for me to hear it? First of all, because a lot of you, they miss it, you should tell me where is the mass. So you will tell me the mass, you will start describing the mass. The majority of you, they forget to tell me where. So either you tell me upper outer quadrant or you tell me clockwise. So you can use the clock, 2 o'clock, 3 o'clock. It's much easier for you because in the exam, sometimes you have a mind block. You will make it by, if you tell me the clock, you make a mistake. So just say upper outer or lower outer or inner or outer or upper. So number one, I need to hear the site. Where is it? Then number two, the size. What is the size? Again, I'm not asking you to give me the exact size. I'm accepting 2 by 2, 3 centimeter, up to 4, I'm accepting. But if somebody come and tell me this is half centimeter, how did you feel it if this is half centimeter? And if somebody come and tell me 10, 20 centimeter, how come it's 10 or 20? So be reasonable. And feeling from hand to hand is not the same. And I don't ask you to bring a measurement and measure it. Just give me roughly assumption. 2 by 2, 2 by 3, 3 by 3, 3 by 2, 2 by 4 is all acceptable. But more than that, that means you are just making it up. So number one size, then the size. Then you have to tell me if this is mobile or not. Is it attached to the skin or the underlying muscle or not? Is it regular or not? Smooth or not? Firm, hard, or soft? This is what I want to hear in the exam.
Okay. So to repeat that, you said mobile, smooth.
No. Number one is.
If it's mobility, right?
Number one is.
Yeah. For the criteria, it's size. It's size. Then it's size.
Who's speaking? Mishari.
Yeah.
Mishari, my son is Mishari, and he's sitting with me now.
Okay.
Number one is the site. Tell me the site. This is what I want to hear first.
Okay, I got it. Okay, makes sense.
Site.
So size.
Yes. Yes.
Then it's mobility and the other characteristics.
Yes, exactly.
Okay, perfect. Thank you so much.
You're welcome. Clear for everybody? And I think you hear him very clearly. We have superficial and we have deep palpation. We may ask you in the exam. Superficial palpation looking for what?
Tenderness and temperature and masses.
And superficial mass. So the superficial palpation looking for tenderness, hotness, and superficial mass. Deep palpation looking for what?
Deep masses.
Deep masses, tenderness, and the characteristic or the features of any mass. So when you feel the mass, you should not tell me the feature of the mass in the superficial. You tell me in the deep. And nobody tell me deep palpation to look for the temperature. Temperature is for superficial. Clear?
Doctor, for deep palpation, for the mass, deep masses, and what else?
I didn't hear you. For the deep palpation, what?
We're only looking for the deep masses, like the characteristic. What else do we look for?
You look for the deep masses. There sometimes you cannot feel the mass in the superficial palpation. So by deep palpation, you have to look for deep masses. If there is any mass which you figure it out in the superficial palpation, you will do the deep palpation to have the characteristic of this mass.
That's it? Like there is nothing else?
And deep and tenderness. Still you can do the deep palpation for tenderness, but you don't do the deep for the hotness, for the temperature.
Okay. Thank you, doctor.
Okay. You're welcome. Any other question? This is very important and most likely you will have it in your SK exam.
I have one, doctor.
Yes,
doctor. In the video he said, in the video he said that superficial mobile number while attached to the skin. How would we know that? Like if it's attached to the skin only or not to the deep structures of the breast? Or it's not important?
If the mass is mobile, that means it's not attached to the skin or the muscle. If you find difficulty to let the muscle move in your hand, that means there is an attachment. Usually, if there is attachment to the skin, you will see skin tethering or skin traction. If there is nothing in the skin, that means the attachment most likely is from deep, so from the muscle. Did this answer your question, Osama?
Yes, thank you so much.
You're welcome. Any other question? Just in case, I'm allowing you to take the photo for the link so you can watch it again once, twice, 3 times until you are familiar with the dummy. I don't want you to be in panic in the exam. Okay?
Thank you, doctor.
Can I go to the next slide now? Or if you have any question, ask. Feel free to ask. Okay, so let's go to next. Anybody can, and I'm doing this for you to just refresh your knowledge. I know this is not the breast, but this is what skin traction looks like. Clear? So you will see something like that, but in the breast. You may see it here. If this is clear for you, here there is skin depression or traction. There are some nipple inverted, and I will say thickness, redness of the breast tissue. It could represent body orange, but it's not that clear body orange appearance. Okay. Here again, this is buckling of the skin or skin tethering and traction. And the nipple is retracted. Clear? In the dummy, you find difficulty, the majority of the student, to differentiate between the redness, the rash, and the body orange appearance. When there is a redness, that means this is rash. Just mention that there are some skin changes, redness or rash. The body orange appearance in the dummy, you can see some thickening, and the pores of the skin is really very like dots. You will see it very clearly. It just looks like the orange peel. Then let's go to the next. Also, this is may come in the exam. Let us see. We finish from Muhammad. Let us see if the rest they are still awake. Bana.
دكتور عادي سؤال بس.
تفضلي.
The skin tethering or skin retraction, usually it's in breast cancer. And what does it indicate mostly?
It's indicate there is some abnormality behind this skin, which most likely it's cancer, but it can happen in inflammatory process. So it could be either cancer or inflammatory process. When we see it, we have to rule out carcinoma. Clear?
Yes, thank you, doctor.
Body orange mean lymphatic obstruction. And again, lymphatic obstruction could be due to cancer or due to inflammatory process. But when we see it, we have to rule out malignancy. Then let us go back to Bana.
Yes, doctor.
Bana, describe what can you see in this photo.
On the upper right, I can see exophthalmos.
Yes.
Protruding eyes.
Okay. Exophthalmos. Then?
Pretibial
myxedema.
Yeah, myxedema.
Why did you say this is a myxedema? Myxedema معناته there is an edema with redness. في rash, في redness.
Yes.
Clinically, it's non-pitting edema, but there is edema with redness. So, and we brought the other feature of hyperthyroidism. So this is most likely is mixed edema. طيب, what else? يعني في شوية goiter. ما هو that's clear, but there is a goiter. What's here? Exophthalmos. This lady is this one.
Yes. Okay.
Exophthalmos. Preorbital edema, conjunctivitis. So this is most likely
Graves.
Hyperthyroidism, Graves. How would you confirm your diagnosis, Bana?
TSH.
Okay. And
T4 TSH.
Okay. So TSH, T4. What else? You said Graves. How can you diagnose Graves? Antibodies.
Yeah.
So TSH, T4, and antibodies. Okay. This is very important. Graves is a very common OSCE question and even written. Okay. How would you manage Graves, Bana?
Could be radiation.
Thank you, Bana. Let us ask Dr. Alauddin. Thank you, Bana. Alauddin, how would you manage Graves?
Yes, right here. Do you do radioactive iodine?
let us be systematic. So Graves or hyperthyroidism should be treated first by medicine, drugs. In the exam, you will be asked about the names of the medication. So you have to review it. You have to know it by heart, all of you.
Okay,
so number one,
propylthiouracil.
Yes, and carbamazole and beta blockers.
Methimazole, yeah.
And beta blockers. If you forget it, at least say beta blockers. Then this is number one. Number two, or second option or second stage for treatment is, as Dr. Abana said, radioiodine therapy ablation.
Okay.
Third option and last option is surgery. What type of surgery in Graves?
Not sure, honestly.
Total thyroidectomy. So Bana and Dr. Aladdin repeats, how would you manage the Graves?
You start with propylthiouracil, beta blockers for the first medication, and then for the second you do radioactive iodine, and then for the third option you do total thyroidectomy.
Okay, Bana?
Yes, I'll start by propylthiouracil, and then beta blockers, and then radioiodide ablation, and then I'll go with the surgery, total thyroidectomy.
Okay, good. Excellent. You
Doctor?
have to... Yes.
I have a question. When you asked about the management, shouldn't we do the triple assessment first, but then we go and talk about the treatment exactly?
Yes. Yes, we will do the triple assessment. But here already I give you the diagnosis. So how would you treat something that's already reached the diagnosis? If I didn't give you the approach, I didn't ask you what is the diagnosis. Yes, you have to do the triple assessment to give me the diagnosis. Since you ask about the triple assessment, would you do all the triple assessment in Graves?
Yes.
What do you want to do?
History and physical imaging.
What type of imaging?
We do. I forgot the name of it exactly. Thyroid scan.
Thyroid scan. What is the standard in thyroid? What is the standard and aim of imaging in thyroid?
Ultrasound.
Ultrasound. Except in Graves, I don't know who's speaking. Who was with me before?
Me, Mizna.
Mizna, except in this case, you are absolutely right. We will do the thyroid scan. So the only indication for a thyroid scan is the hyperthyroidism. Okay? And the only indication for antibodies is either hyper or hypothyroidism. So in this case, we will do the thyroid scan, as you said, Mizna. But why should we do the thyroid scan in hyperthyroidism?
To see hot and cold areas?
No. We'll do the thyroid scan only in Graves or hyperthyroidism to be able to diagnose, is this a Graves? So it will be diffuse goiter, and in case we want to do surgery, it will be total thyroidectomy. But if this is only one hot nodule in one loop, if we need to do surgery, it will be only hemithyroidectomy. So it will help me to do the surgery, not to diagnose. The third reason behind the thyroid scan, sometime in very rare cases, the hyperthyroidism is secondary to another tumor, not because of Graves or hot nodule, like ovarian stromal. Sometimes some tumors, they secrete a stimulated with like the thyroglobulin and make the thyroid hyperactive. In this case, surgically, if I remove the thyroid, the patient will not get benefit from the bang surgery. The tumor should be treated. So this is the reason we do the thyroid scan. We never use the thyroid scan to diagnose cold or hot. I can diagnose the patient by ultrasound and labs. So I know this is hyperthyroidism from the labs. But the thyroid scan is very important to help me to decide my surgery. Is it thyroid or the whole thyroid? Is it only hot nodule? Or there is something extra thyroid behind the hyperthyroidism status. But by the end, we have to bring the patient euthyroid first, then do the ultrasound again. Clear?
Clear, thank you, doctor.
But I agree, Ms. Na, if I ask you how would you approach the patient, yes, totally agree, you have to do a triple assessment. But because I asked Ban, I told her this is Graves. How would you confirm your diagnosis? Here is, I'm not asking you to do the approach. I'm asking you to confirm the diagnosis of hyperthyroidism. So to confirm it, you have to do the TSH and the antibodies. This is to confirm your diagnosis. If the TSH is low, T4 is high, antibody is positive, I reach the diagnosis. Clear? The other question, actually, do I need to do biopsy in Graves?
No.
No, because Graves is clinical diagnosis. If the ultrasound of the patient with Graves showed a mass or nodule, I will take biopsy from it, but I will not take it just because it's Graves. And I cannot take it until I bring the patient euthyroid. That's why we start with thyroid scan, treat the patient, then later on we'll do the ultrasound and the biopsy. And this is the exception, the only exception in our triple assessment in thyroid, and it's fatal. That's why we bring it in the exam. Clear?
Doctor, can you please repeat the last point?
Thyroidism. If you stress the patient will have arrhythmia. The patient will end by thyroid storm. The patient may die because of hyperthermia and arrhythmia. So in Graves only, or hyperthyroidism in general, we do thyroid scan, we treat them medically. Until they become euthyroid, then we will do the ultrasound, and if there is a nodule, we'll do biopsy. Clear?
Yes, doctor.
Everybody clear, or should I repeat anything?
Yes, doctor. So we always make it a euthyroid, then we do our procedures, whatever they are.
Yes. Otherwise, the patient will go for thyroid storm, and the patient will develop hyperthermia, hyperarrhythmia, then the patient may die. Okay? And this is the only exception for our triple assessment in thyroid. Yes?
So in thyroid, we always do ultrasound unless if the patient has hyperthyroidism. We do the thyroid scan. We treat medically to reach euthyroid state. Then we perform surgery. And then we do ultrasound. If there's a mass or nodule, we do biopsy. So?
We will not do surgery. Why should I do surgery? The treatment is medical. Bring the patient euthyroid, then do the ultrasound. If there is a reason for surgery, we'll take the patient to the surgery. If there is no need for surgery, no need for surgery. The majority of them, they respond to the medical treatment. But in the box, they will write for you, and even clinically, if the patient has severe eye manifestation, in this case, we need to bring them euthyroid, then do the surgery. But we will not interfere surgically until they are treated medically. If they fail to treat them by medicine or drugs, they should do ablation. Then we will consider the ultrasound. Why we are doing the ultrasound? To give us more details about the thyroid. If there is a nodule in the ultrasound, I need to biopsy it. The patient may have Graves and cancer, I don't know. So bring the patient euthyroid, do the ultrasound, and if there is indication for surgery, I will do the surgery. If there is no indication, no surgery. Clear?
Yes, thank you, doctor.
Clear? Should I repeat anything for anybody?
No, everything is clear. Thank you so much.
Okay, great. Yeah, next. So this is the thyroid scan. Okay. Here you can see this is the thyroid, and this is a cold nodule. Does that mean anything for me? No. Do I need to biopsy this cold nodule? No. If there is something, I will do ultrasound, and based on the ultrasound, I will decide if I need biopsy or not. This one, you can see the uptake. The black one is high uptake. That means the gland is hyperactive, hypermetabolic. So this is diffuse uptake. Diffuse uptake mean grapes. So this is grapes. In case I plan surgery for this patient, it should be total thyroidectomy. This one here, this is a nodule, this is a nodule. So there are multiple hot nodule and they are in both loop. So in case also I need surgery, in this case, I need to do total thyroidectomy. This one, this is the thyroid. It's only one hot nodule, hypermetabolic nodule. In the exam, we bring the thyroid scan. So you need to tell me this is thyroid scan and this is a hypermetabolic hot nodule. Then you have to tell me this is right or left. Remember, usually the imaging is just opposite to you. So your right is the left for the patient. Your left is the right for the patient. So just the opposite. So this one here, there is a nodule in the right or left?
Left.
Right.
Oh, okay, so left side. This is the right. For me, this is the right. I'm facing it. So this is my left. So this is the right of the patient. You get it? الحين you are facing the imaging, صح? Like me.
Right.
You are facing the image. So if I ask you which hand is opposite to this loop, is it the right or the left? Your left hand.
So we don't confuse.
So it is the right of the patient. No?
So just we don't confuse things. Which picture are you pointing at? Because I don't see the arrow.
This one.
Okay. Oh, okay, that makes.
Who's next? Let me see. Let me see who's next with us. Mishari, can you please remove your hand? Badr, Dr. Badr.
Yes, I'm here.
Okay, can you see? Whatever here.
Maybe.
This is the renal.
Adrenal.
This is above the renal. What is it? Adrenal. And I'm an endocrine. So if you see me in the exam and I brought this, I will not bring a renal. I will bring adrenal. Okay,
yes, yes.
And this is again here. And okay, so usually we'll bring either one, or she has and she found to have this mass. So what do you think? What is the most likely diagnosis?
Pheochromocytoma?
Yes, pheochromocytoma. How would you confirm your diagnosis?
So we do 24-hour urine collection of methanephrine's VMA, HVA, catecholamines, and then when it's positive, and then we go for the CT, and then we find these findings in the CT.
Dr. Badr, one by one. How you confirm? You confirm your diagnosis by CT?
Yeah, I'm guessing so, yeah. And the catecholamines from the 24-hour urine collection.
Your answer, Faris, is correct, but CT scan is not confirmation. So as you said, we will do 24-hour collection for catecholamine and the metabolism. This is to how to confirm. That's it. You will do the CT scan for localization, not for confirmation. Clear? Okay, so if I ask you how would you confirm, you will tell me?
24-hour urine collection of catecholamines and plasma-free also catecholamines.
Okay, excellent. Well, and the CT scan is only for localization. Excellent, Dr. Badr. Okay, so let us go for Dr. White.
Yes, doctor.
Okay, how would you treat this patient?
Excision of the pheochromocytoma.
Yes, so adrenalectomy or removal of this is the curative surgery. Anything you have to tell me before the surgery?
Yes, we have to give alpha blockers and then beta blockers.
Excellent. Clear for everybody? This is a common scenario, again, because it's very important and fatal, we bring it. Pheochromocytoma is not a common problem, but it's really fatal. And you have to consider it in any young patient with high blood pressure or uncontrolled blood pressure. Clear?
Doctor,
Yes, doctor.
can you just repeat how do we confirm the diagnosis? 24-hour urine catecholamines?
Yes, metanephrine, and mandelic acid. So a metabolism, and you can also ask for plasma metanephrine. Metanephrine products and plasma metanephrine. And if you say the 24-hour urine, I consider it correct. Yani if you didn't say the plasma, it's okay with me. Halas?
Yes.
But I need to know that you understand which product you need to ask for. And you have to know, and you have to start with the alpha beta blocker, and then after 2 weeks, if not controlled beta blocker, then surgery. Okay?
Yes.
Any other question, or should I go for next? Okay, so next. Before I go, thank you. One more common scenario. We may ask you about the primary hyperthyroidism. So you need to know what are the causes of primary hyperthyroidism. Let me go to Dr. Rabah.
Doctor.
Okay, Rabah. So, Paris, how would you confirm the diagnosis of primary hyperparathyroidism?
By measuring the level of the PTH and the calcium.
Excellent. And how would you manage it?
By surgery.
Surgery. So just tell me surgery, parathyroidectomy. I don't ask you to tell me more details. So I didn't ask you remove 1 or 2 or 10. I didn't ask. Just tell me parathyroidectomy. Clear? Okay, then we'll go to Hala.
Yes, doctor. Hala.
Doctora Hala. What are the causes for primary hyperparathyroidism?
It could be related to the parathyroid itself, like hyperplasia, adenoma.
Hyperplasia or
cancer.
Or cancer. So that's all. Mafi other reason for it's primary, so it's from the parathyroid. It's either single adenoma or hyperplasia or cancer. Clear?
Yes.
Do you have any more questions? I think that I review the most important topics for breast and endocrine.
Thank you so much for your time.
Good luck in your exam, inshallah. But if you have any question, let me know. طيب?